Good afternoon. I'm Dr. Ekam Jyot Singh. I'm a senior resident Department of Neuroradiology, AIIMS Delhi. I'll be presenting on the topic of intracranial dural AV fistulas with the focus on etiopathology, classification, and the management. So first of all, what is a dural AV fistula? Basically, it's an abnormal communication between artery and a vein, and it is located within the dura. And it's an abnormal arteriovenous communication between the dural arteries and the dural sinuses, or meningeal vein, or the cortical veins. So here in this representative image, we can see that this is calvaria. This is thick dura mater, which contains the dural arteries. Then we have arachnoid matter and pia with the cortical veins. We can appreciate that there is an abnormal connection here between the meningeal artery and one of the cortical veins. So this is how a dural AV fistula looks like. Again, another image in which we can see that there are three components of a dural AV fistula: an arterial component, the fistulous site, and then there is a venous component. The arterial component here is represented by the occipital artery. Then we have a fistulous component, the abnormal connection of occipital artery branches with the transverse sinus, and the venous component is the transverse sinus itself. And this is how it looks radiologically on a DSA. This is the DSA lateral view of occipital artery run. This is occipital artery. We can see that there are multiple feeders that are draining into the transverse sinus directly. So the arterial component here is occipital artery, and there are multiple fistulae, and the venous component here is the transverse venous sinus. So epidemiology, a little bit about it. These are rare lesions. So detection rate is less than 1 in 1 lakh. And these lesions, they occur at the age of 50 to 70 years. They have slight female preponderance. They constitute about 10 to 15% of all the intracranial vascular malformations. The location, the most common location is transverse and sigmoid sinuses. Approximately 45% of the lesions occur here. The second most common location is the cavernous venous sinuses. And other major locations where these lesions occur include superior sagittal sinus, tentorium cerebelli, anterior cranial fossa, and foramen magnum. And then we'll discuss the etiological factors that are associated with the formation of a dural AV fistula. So these lesions are largely acquired in nature, and they are predominantly idiopathic. A small percentage of the patients, approximately 20% of the patients, have underlying associations, which include venous sinus thrombosis, head trauma, transcranial surgery, increased systemic thrombotic tendencies such as protein C or protein S deficiency, and association with the pregnancy, use of oral contraceptives, and tumors such as meningiomas. So there are two etiologic hypotheses that explain the formation of a dural AV fistula. The first one is a Gingian's concept, which basically says that there is hypertrophy of the physiological AV shunts that normally occur between the meningeal arteries and the dural venous sinuses in response to the elevated local venous pressure, which could be secondarily to the outflow obstruction, secondary to thrombosis or stenosis. Then there is another concept, that is Uranishi's concept, which states that the venous hypertension due to outflow obstruction, it causes decreased cerebral perfusion, and this results in a sort of cerebral ischemia, and this promotes neoangiogenesis and hence causes the formation of a dural AV fistula. So this is how the cascade of event occurs in the formation of a dural AV fistula. Tumors, trauma, and congenital sinus stenosis or malformations, high risk factor for thrombosis or previous history of venous thrombosis, all of these cause high venous sinus pressure. And this high venous sinus pressure, it causes the opening of the physiologically occurring AV shunts. These AV shunts, they enlarge over time, and this results in the formation of a dural AV fistula. This is what we call Gingian's concept. And then in another concept is, it also causes obstruction of venous drainage, which results in cerebral hypoperfusion. And this cerebral hypoperfusion, it induces cerebral ischemia and hence upregulation of hypoxia-inducible factor 1 alpha and VEGF. And raised levels of VEGF and HIF1 alpha, it causes neovascularization, and hence it results in the formation of a dural AV fistula. This is what we call Uranishi's concept. Then there is also embryological basis of the classification of dural AV fistula. It was put forward by Givi Prasad and Lars Junius in 2005, and it is based on the embryological region of three discrete epidural venous systems, namely the lateral, ventral, and the dorsal one. We'll discuss this in detail in next slides. So basically, they say that the crinospinal epidural spaces, they are categorized into three different compartments. The ventral one, which is marked here by the blue, the dorsal one, which is marked here by the brown, and the lateral one, which is marked here by the green. So the ventral epidural group, it includes the lesions in the cavernous sinus, basis sphenoid, and basi occiput. The dorsal one, it includes the lesions in transverse sinus, torcula, and medial occipital sinus, as well as in the superior sagittal sinus. And the lateral one, that includes the lesion in the anterior cranial fossa, especially the cribriform plate and sphenoparietal sinuses. So first of all, we'll discuss the ventral epidural group. It includes the fistulas that are in direct contact with the spongious bony structures and includes the lesions in basi occiput, basi sphenoid, petrous bone, and sphenoid wings. Approximately 50% of the fistulas belong to this group, and these lesions are more common in females. These lesions are usually have a benign presentation, and there is no reflux until unless it is a very high flow shunt or there is thrombosis of the epidural drainage. Then, in the dorsal epidural group, it constitutes about 22% of the dural AV fistula, and major of these are superior sagittal sinus fistulas. There is no sex predominance in this case. Lesions are usually multiple. They have lower mean age and includes the lesion in superior sagittal sinus, transverse sinus, sigmoid sinus, medial occipital sinus, as well as posterior marginal sinus, and at the level of torcula. These lesions usually don't have any cortical venous reflex until unless, again, there is very high flow shunt or there is extensive thrombosis. Then we have the most dreadful group, that is the lateral epidural group, which constitutes about 21% of the total lesions, more common in men, and includes the lesions in marginal sinus, vein of Galen, petrosal and basitentorial sinuses, Bresch's sinus, sphenoparietal sinus, and lamina cribriformis, and so forth. These are the most aggressive group, as there is direct cortical venous drainage seen in this group, and so therefore they have a high rate of overall hemorrhagic transformation. So coming on to the classification systems of the dural AV fistulas. So basically there are three main classification systems: the Gingian's classification, Cognat classification, Borden classification, and all of these say that there is the defining angiographic feature that differentiates from benign from aggressive lesions is the presence of a cortical venous reflux. So this is a table depicting all the three systems. The Gingian system, it has four subtypes. Type 1, where the drainage is directly into the venous sinus or a meningeal vein. In type 2, there is drainage into the venous sinus, but now there is a reflux into other sinuses or the cortical vein. In type 3, the initial is directly draining into the cortical vein itself. And in type 4, there is formation of a venous pouch into the cortical vein. The Cognat and Borden classification we'll discuss in detail in next slides. So the Cognat classification, it has 5 subtypes. The first subtype, here we can see that in this diagrammatic representation, the fistula is directly forming at the level of sinus itself, and there is anterograde flow. The normal anterograde flow is preserved. So this is the radiological correlate of the same. This is the occipital artery run. We can see that this is the occipital artery. Again, the same image. We can see multiple fistulas draining into the transverse venous sinus, and there is anterograde flow. So this is a type 1 Cognat fistula. Coming on to type 2, it's further divided into type 2A and type 2B. In type 2A, there is drainage into the dural sinus, but now there is retrograde flux into the sinus. This is a radiological correlate of the same. This is an example of a torcular fistula. We can see that there is opacification of both superior sagittal sinus as well as the sigmoid sinus, and so there is a retrograde flow into the superior sagittal sinus, thus classifying it as a type 2A dural AV fistula, Cognat type. In type 2B lesions, now there is the fistula is at the level of dural sinus, but now apart from the retrograde reflux into the sinus, now there is reflux into the cortical veins as well. Here in this image, this is the occipital artery run again. We can see that this is the occipital artery which is dilated and tortuous and has multiple feeders that are draining into the transverse sinus, and there is retrograde flow into the superior sagittal sinus, anterograde flow is seen into the sigmoid sinus. Plus we see that there are multiple dilated cortical veins as well. So now it classifies as a type 2B Cognat type. In type 3 cognate type fistula, the fistula is directly at the level of cortical vein. Hence, retrograde flow into the cortical vein is present. In this radiological representative image, we can see that this is occipital artery itself. It is directly draining into one of the cortical vein with the retrograde flow in the cortical vein, which is markedly dilated and ectatic. In type 4, the fistula is again at the level of cortical vein only, but now there is venous ectasia that is present. The venous pouches they have formed in type 4. Again, in this occipital artery run, we can see this is the occipital artery directly draining into one of the cortical veins. The flow is retrograde and there is formation of a ectatic venous pouch here. This is type 4 cognate dural AV fistula. In type 5, the fistula is directly draining into the spinal perimedullary veins, and hence the patient can present with the features of congestive myelopathy. In this ICA run, we can see the fistula is directly, we can see reformation of the spinal perimedullary veins due to the reflux into the veins. So this is type 5 cognate fistula. Then the modern classification is relatively simpler. It has 3 subtypes. Type 1, where the venous drainage is directly into the dural sinus and there is preserved antegrade flow. In type 2, there is retrograde flow into the sinus with evidence of cortical venous reflux. And in type 3, the lesion is draining into the isolated sinus segment or into one of the subarachnoid veins. A few lines about the natural history of the fistula. Soderman et al. They reported the annual rates of hemorrhage of 1.5 and 7.4% in unruptured and ruptured dural AV fistulas respectively. The Hauser et al. They were first to report the relationship of the cortical venous reflux with the intracranial hemorrhage, and they reported odds ratio of about 17.5%, which is quite high. Low grade fistula, yes, it can convert to a higher grade, and the causes in this case will include venous stenosis, recruitment of new feeder vessels, and insidious increase in arterial flow in pre-existing arterial feeders. Yes, the fistula can spontaneously undergo resolution. The rate of resolution for a low-grade fistula, that is cognate type 1 and 2A, are 13%. For the higher grade fistulas, it is approximately only 3%. The clinical manifestation, they depend upon the location of fistula firstly and the pattern of venous drainage. And most of the symptoms, they are due to impaired venous drainage. The patient might present with the clinical features of increased intracranial pressure, papilledema, and they might present with a transient or persistent neurological deficits. Pulsatile tinnitus is observed when the fistula involves the petrous region and drains into the transverse or sigmoid sinus. The aggressive features that we have to note in a case of a dural AV fistula are intracerebral hemorrhage, subdural hemorrhage, and subarachnoid hemorrhage. All these features are directly related to the presence of cortical venous reflux. Then clinical features, as we have said, that they depend upon the location of the fistula. In case of a superior sagittal sinus fistula, the benign symptoms that are observed are headache, while aggressive symptoms that we have to note, they are intracranial hypertension, presence of dementia, or presence of focal deficits. In case of a transverse sinus or sigmoid sinus fistula, the benign features are headache, hydrocephalus, trigeminal neuralgia, tinnitus, earache, while the aggressive features are presence of temporal lobe dysfunction. In case of a temporal dural AVF, the benign features will be hemisensory alterations, facial paralysis, trigeminal neuralgia, tinnitus. The aggressive features will be visual disturbances, intracranial hypertension, and dementia. Anterior coronal fossa DAVF, the benign features here are chemosis and proptosis, while the aggressive features, they include intracranial hypertension, encephalopathy, ageusia, visual disturbances, and dementia. So a little bit about imaging. CT, it might reveal the asymmetry of the dural venous sinuses or enlargement of the, let's say, cavernous sinus is involved. We can see enlargement of the cavernous sinus or the superior ophthalmic vein. It might also depict the bony defects that have resulted from the enlargement of the emissary veins. The critical findings that we have to note in case of a dural AV fistula are intracranial hemorrhage, subarachnoid hemorrhage, presence of increasing hydrocephalus, and vasogenic edema that is related to the cortical venous reflux and which is leading to the cortical venous hypertension. And chronic venous congestion, it is seen as a hypodensity on CT scan. The magnetic resonance imaging, after CT, the first investigation the patient usually undergoes is magnetic resonance imaging. Here we can appreciate the presence of dural thickening, flow voids without a parenchymal nidus. A thrombosed venous sinus might be seen on the CEMRV. Dilated cortical veins that might be appreciated in a case of a dural AV fistula. Presence of white matter edema, it is also appreciated on the T2 or FLAIR images. A combination of a subdural hemorrhage and of intraparenchymal hemorrhage is indicative of a dural AV fistula. We should always look for a dural AV fistula when there is subdural and intraparenchymal hemorrhage. And ASL imaging is quite useful. In case of a dural AV fistula, like in this case, this is the case of superior sagittal sinus dural AV fistula, we can appreciate the hypersignal on ASL images in the superior sagittal sinus, which suggests the arterialized flow within the sinus, and hence ASL images should be included in the protocol when a dural AV fistula is suspected. Other features of aggressive fistulae on MRI: diffuse white matter edema, which is secondary to venous congestion and parenchymal venous strain, diffuse cortical enhancement, dilated pile vessels, and sequelae such as infarction and hemorrhage. So DSA, it is the gold standard for the diagnosis and assessment. The 6-vessel angiogram should be done, and it should include the face and upper neck in the field of view. Magnified high frame rate images should be taken, which should be centered on the fistulous point. What are targets in case of a DSA imaging? We have to identify the fistula site, arterial feeders, sinus occlusion, venous drainage, and presence of cortical venous reflux, any venous ectasia, stenosis, or flow-related aneurysms. This is the representative DSA images. That's how a DSA images look like in a case of a tentorial dural AVF. You can see that this is a right ECA run. There are feeders from the occipital artery which are draining into the precentral cerebral vein, which is further draining into the straight sinus and further into transverse and sigmoid sinus. There are feeders from the meningeal branches of the PCA on RVA runs, as well as there are feeders from left occipital artery and meningohypophyseal trunk, which are draining here. We can also appreciate the venous ectasia here. So classifying it as a type 4 cognate type. There are also feeders from right ACA. The meningohypophyseal trunk is also supplying this fistula on right side. So about the management of the dural AV fistulas, there are 3 possible managements: the endovascular management, microsurgery, the gamma knife radiotherapy. We'll discuss the endovascular management. It can be either transarterial or transvenous, and we can use either coils, liquid embolics, glue, onyx, or particles. In transarterial embolization with coil, it was one of the primary methods of endovascular treatment prior to the advent of liquid embolics. It was useful in fistulas with large venous sacs and in particular cavernous sinus dural AVFs. However, its disadvantages are it can result in the incomplete obliteration of the fistula. In case of a fistula with multiple feeders and in multifistulous type of dural AVF, it can result in a dural residual lesions that are being present. So this is one of the cases from our department which we did with coils. The patient presented to us with the chronic headache from 8 months and tinnitus in left ear from 8 months. There were no appreciable deficits on neurological exam. These are representative axial CT and MR images. We can see that there are multiple dilated venous channels which can appreciate in the left CP angle along the petrous apex in left sylvian fissure. Note that there is no evident nidus formation. So this is basically this basically raises the possibility of the presence of a petrous dural AVF. So a diagnostic DSA was performed in our department. In this diagnostic DSA, these are the left ECA runs. We can appreciate that there are multiple feeders, with the largest feeder from the middle meningeal artery. There are feeders from the STA as well. There are feeders from the occipital artery, which are dilated, which are draining into large venous sac, which is refluxing into the basal vein of Rosenthal hair. In left ECA runs, we can appreciate the meningohypophyseal trunk. It is also draining into the dural, it's also draining into the venous sac. In the vertebral artery runs, we can see that the meningeal branches from the vertebral artery as well as the branches from PC are also contributing to the dural AV fistula. So summary of our findings, we have a left petrous dural AVF with feeders from left MMA, STA, occipital artery, meningohypophyseal trunks and meningeal branches of vertebral artery and PCA. The treatment strategy that we employed in this case was transarterial endovascular coiling of the large venous sac, as most of the fistulae are ending there. These are the intervention consumables that we used in this case. The guiding sheath that we used was 6 French Neuron Max 80 centimeter. Intermediate catheter was 6 French Fargo Max 105 centimeter. Micro catheter was Echelon 010. Large micro wire was Transcend 014. And the large coil, 14 down coils were used. The arterial access here is taken via the middle meningeal artery. We can see the micro catheter in the middle meningeal artery here. And the fistula was coiled with the coil mass placed in that large venous sac that we saw earlier. And these are the check runs which were taken after the coiling. We can see that there is complete obliteration of the fistula in ECA runs. And the patient also clinically improved with the resolution of the headache. Then Onyx. Onyx is basically ethylene vinyl alcohol copolymer. Its first use was described by Taki et al. And Terada et al. Basically has three things: dimethyl sulfoxide, which acts as the solvent and prevents the polymerization of the ethylene vinyl copolymer, the ethylene vinyl alcohol copolymer itself, and the tantalum powder, which provides it the radio opacity. So, mechanism of Onyx is depicted here. So, Onyx, when it comes in contact with an aqueous solution, it causes the precipitation of the polymer, which is initiated by the diffusion of DMSO wave from the EVOH. And this precipitation, it begins on the surface while the core is still a liquid. This results in the formation of soft non-adherent mass-like lava flow-like pattern of the onyx, which causes the permanent vascular occlusion. Then there is glue. Glue is basically N-butyl 2-cyanoacrylate. It exists as a liquid in the monomeric state, but on contact with the ionic solution, it polymerizes and solidifies in a few seconds. And it's mixed with lipidol, which provides its radio opacity and delays the polymerization. Advantages of glue are it is cheap, economical, and it has high thrombogenicity. While the disadvantages, it's very difficult to control a glue injection as it polymerizes the instant it comes in contact with the ionic solutions. So this is the impact table depicting the impact of Onyx. We can see that the total number of recruited cases compared to the pre-Onyx era, they have significantly increased, while the obliteration rate, cure rate, they have significantly improved, and the need for subsequent surgery is significantly decreased. The transarterial embolization with Onyx or glue, our aim here is to occlude the fistulous point and the foot of the draining vein via distal artery, which is typically MMA in most of the cases. The anatomic locations that are suitable for transarterial embolization include cerebral convexity, transverse sinus, lateral tentorial region, and superior sagittal sinus. We have to ensure that there is relative safe distance between the fistulous point and the cranial nerve supply from the dural arteries. And we also have to avoid the major ECA, ICA, and anastomosis that exist. The dorsal and lateral epidural location, they are ideal for transarterial embolization. So basically, three major ICA, ECA, and anastomosis that are present. The first one is orbital, which is present, which is depicted here, and it is between the branches of the MMA or internal maxillary artery and ophthalmic artery, which is the branch of ICA. Then we have petrocavernous anastomosis, where the branches of MMA and IMA and the branches of cavernous ICA, which are basically ILT and meningohypophyseal trunk, they anastomose. And upper cervical anastomosis, where there is anastomosis between the ascending pharyngeal occipital artery D and ascending cervical branches with the odontoid, muscular, and posterior meningeal branches of the vertebral artery. Again, we have to avoid the cranial nerve ischemias because there is also dural supply to the various cranial nerve that exit through the various foramina. Like the middle meningeal, it gives branches to the foramen spinosum, and accessory meningeal, it supplies the foramen ovale where there is V3 branch, and foramen rotundum there is V2 branch. We have to take care we don't embolize these branches, or otherwise it can result in cranial nerve ischemia of the nerves passing through these foramina. Then ascending pharyngeal artery is very important. It has two major branches that supply the cranial nerve. The neuromeningeal trunk, which supplies the 9 to 12 branches, 9 to 12 cranial nerves, sorry, and inferior tympanic arteries. We have to be very careful that we do not embolize these branches while embolizing the dural AV fistulae. So case study of our department, transited arterial embolization was done with Onyx in this case. This was a 58-year-old patient who presented to us with a history of chronic headache from 3 to 4 years. No deficits were noted on clinical examination. This was the outside imaging that we had where axial T2 image. In this axial T2 image, we can see that there is a dilated large venous sag was noted. A limited MR films are available. So keeping in view that there is a venous sac, here vascular imaging was required. So a DSA was performed in our department. So these are ECA runs on right side, AP and lateral view. We can see that there are feeders from occipital artery that are draining into the precentral cerebral vein, which is further draining into straight sinus, and via transverse sinus and sigmoid sinus, it is draining outside the brain. There are feeders from middle meningeal artery as well. In vertebral artery runs, there are feeders from meningeal arteries. On left side, there are feeders from occipital artery as well as the meningohypophyseal trunk. On right side, the meningohypophyseal trunk is again supplying the lesion. So our diagnosis is the tentorial dural AVF with feeders from occipital branches of bilateral ECA, meningohypophyseal trunk, meningeal branches of PCA. The venous drainage is into the precentral cerebral vein, which shows venous ectasia and further draining into the straight sinus. So due to the presence of venous ectasia, this is a cognate type 4 fistula, and the treatment strategy that we employed in this case was we were using Onyx 10 via transarterial route. So the axis was taken from a right transfemoral 8 French axis was taken. These are the intervention consumables that we used in this case. The guiding sheath was 6 French Neuron Max 80 centimeter. The intermediate catheter that we used was 6 French Navian. Micro catheter was Sonic 2.1 French, and micro wire was Transcend 014. So our arterial access here is via middle meningeal artery branches. We can appreciate the presence of a micro catheter in middle meningeal artery. We took it up to the fistulous point, took a micro catheter run, which revealed the presence of dural AV fistula draining into precentral cerebral vein. We injected Onyx here, and these are our post-ambo check runs, which reveal the complete obliteration of the fistula. The patient improved clinically with resolution of the symptoms, especially the headache. There was no headache on follow-up imaging, on follow-up clinical exam, or then another case where we did transarterial embolization with glue. The patient presented to us with the complaint of pulsatile proptosis of left eye, which was persistent from 1 year, and there was chronic headache and decreased vision of left eye. A diagnostic DSA imaging was done in this case. We can see that this is the left ECA run, and there are feeders from the middle meningeal artery as well as the accessory meningeal artery, which are draining into the superior ophthalmic vein, which is dilated. And further, this superior ophthalmic vein is refluxing into the facial vein, as we can see here. Again, on this AP images, we can appreciate the same, the feeders from middle meningeal artery and accessory meningeal artery draining into the superior ophthalmic vein. So our diagnosis here is a foramen spinosum dural AVF with feeders from MMA. The venous drainage is into superior ophthalmic vein and further into facial vein. The treatment strategy that we employed in this case was transarterial embolization using glue. The intervention consumables that we used in this case were guiding sheath for 6 French Neuron, intermediate catheter 6 French Navian 105 centimeter, micro catheters were Marathon 010, and micro wire was Mirage 008. So arterial access again via MMA. We went till the fistula site, took a micro run, which revealed the filling of, which showed the filling of superior ophthalmic vein. The glue injection was done in this case. and the post-ambo check runs, they revealed significant slowing of the flow in the superior ophthalmic vein. We can also appreciate glue here in the foramen and spinosum, and the patient symptom markedly reduced with the resolution of proptosis and chemosis. Another case of our department, the patient presented to us with the occipital headache and neck pain from 5 months. There were no deficits on clinical examination. MR images, axial T2 and sagittal T2 images, we can appreciate flow voids at the level of foramen magnum here. This prompted DSA evaluation of the patient. These are left ECA runs and left vertebral artery runs here. These are the lateral images. We can appreciate that the occipital artery is draining into the anterior condylar vein, which is represented here. And this anterior condylar vein is refluxing into the superficial middle cerebral vein. There are some feeders from the ascending pharyngeal artery as well. On vertebral artery run, we again can see the feeders from the meningeal branches of the vertebral artery and the filling of the anterior condylar vein. And reflux is also appreciated in superficial middle cerebral vein. The anterior condylar vein is finally ending into the marginal sinus here. So this is a case of a condylar dural AVF with arterial feeders from LVA and occipital branches of left ECA. The venous drainage is into anterior condylar vein, and which is further draining into marginal sinus with reflux into the superficial medial cerebral vein. The treatment strategy that we employed in this case was transarterial embolization with onyx. These are the intervention consumables that we used in this case. So our arterial access in this case was via occipital artery. We can appreciate this is the microcatheter here in the occipital artery. The run was taken at the fistula site, which revealed the opacification of anterior condylar vein. So onyx injection was made at the fistula site, and the post-ambo check runs here in this case. This is the LVA check run, which revealed the complete obliteration of the fistula, and this is left ECA check run, which again reveals that there is no venous side filling now. This is the onyx cast which we can appreciate on the axial CT bony window in the condylar canal on left side. So a little bit about technical approaches that we use when glue or onyx injections. The first technique that we use is the plug formation. Here what we do is there is slow administration of the onyx, often in slow intermittent bursts, that results in the formation of a plug of semi-solidified onyx around the tip, and it prevents the further reflux of the agent on the arterial side. Then there is a pressure cooker technique. It was primarily employed for the AVMs, and that it was modified to be used in dural AV fistulas. Here we use two microcatheters side by side. One with the detachable tip is placed ahead, and one with the one simple microcatheter is placed behind. What we do is we place coils with the simple microcatheter, and what these coils do, they prevent the reflux of any onyx injection, which is done via this catheter with the detachable tip. So pressure cooker technique is useful in cases where dural AV where reflux is a problem. Then balloon sinus protection. The sinus occlusion balloon is placed here in this case in a relevant sinus, which we need to preserve, and the transarterial embolization with onyx is done via one of the arterial feeders. What this does is there is occlusion. It causes the occlusion of the arterial feeders without any thrombosis in the dural sinus, and it's particularly useful in the cognate type 1 and type 2 dural AV fistulas, where we need to preserve the sinus itself. So this is one of the cases from our department where we did balloon sinus where we used balloon sinus protection. A 20-year female patient who presented with the headache from 5 months and tinnitus in bilateral ears from 5 months. These were axial T2 weighted and corneal T2 weighted images. We can appreciate that there's a large dilated superior sagittal sinus with multiple tiny flow voids in left frontoparietal, high frontoparietal location. Dilated cortical veins are also appreciated in this case. So this prompted a DSA evaluation, which was done in our department. These are left ECA, ICA runs. And here we can see that there is a large superior sagittal sinus dural AV fistula with feeders from middle meningeal artery of left ECA, ophthalmic artery branches, and this fistula is draining into the superior sagittal sinus and further into the transverse venous sinus. The right ICA also, right ECA runs, they also reveal feeders from middle meningeal artery with the presence of cortical venous reflux. There are feeders from the meningeal branches from right ICA as well. The cortical venous reflux is very well appreciated in these venous phase images. So our diagnosis here is a cognate type 2 superior sagittal sinus dural AVA. The treatment strategy that we employed in this case was the transarterial embolization with onyx with balloon sinus protection. The balloon which we used was Copernicus RC. So again, arterial access was taken via middle meningeal artery branches, where we can appreciate the microcatheter in one of the middle meningeal artery branches reaching up to the fistulous point, and via transvenous access, we can see that the balloon was placed into the superior sagittal sinus, and after the inflation of balloon into the superior sagittal sinus, we via transarterial middle meningeal feeder, we injected onyx here, and this resulted in significant obliteration of the fistula. And after 2 to 3 sittings, we can see that there is marked resolution of the dural AV fistula in these check images. The patient is still on follow-up and has markedly reduced clinical symptoms. The complications, the most common complications that we see are arterial ischemic events, stroke, and these are probably due to the ECIC anastomosis that we see. The vessel wall perforation, venous occlusion with hemorrhage are another complication. Vessel rupture is one of the other complications. Non-retrievable microcatheter is observed in 0.2% of the cases. The complication rate are highest in craniocervical junction dural AV fistulas and in anterior cranial fossa fistulas. Then transvenous approach. What are the indications of transvenous approach? Is indicated in dural AV fistulas where transarterial approach is associated with the moderate risk of the following: ischemic cranial neuropathy due to synchronous supply to the vasa vasorum, parenchymal infarction due to the risk of ECIC anastomosis, and an inability to reach the distal embolization position due to the toxicity of the vessels. And these all anatomic and angioarchitectural factors, they are associated with the fistulas in the ventral skull base. This is one of the case that we did via transvenous route. The 18-year-old female here presented to us with the complaint of bilateral ptosis. The representative images of the patient, axial T2 weighted images, we can see there is dilatation of bilateral superior ophthalmic veins. The DSA images reveal a large torcular and transverse sinus dural AV fistula with feeders from middle meningeal artery and occipital branches. There is very severe cortical venous reflux, as we can see here, and there are feeders from meningeal branches of vertebral artery as well as from the PCA. So staged embolization was planned in this case. First, we did transarterial embolization, and the access was again taken from middle meningeal artery, where we did balloon sinus protection technique, and transarterially from MMA, the glue was injected. The check runs revealed the complete obliteration of the fistula, but the patient again presented with the recurrence of symptoms to us. And the second CT after 6 months was done. Here what we did was we took a transvenous approach on right side via transverse sinus. We reached via sigmoid sinus and transverse sinus. We took the microcatheter onto the left side where we employed the coils. On the check runs, we can see that there is no residual filling of the fistula here, and the patient also improved clinically with the resolution of proptosis. Again, on these check runs of the ECA and ICA, we can see that there is a resolution of the disease. And these were the pictures prior to the second sitting and after the second sitting. We can see that there is marked resolution of the chemosis and cryptosis. Then a few lines about particle embolization. It is a role in palliation of symptoms and indicated when there is difficult transarterial embolization or coiling, and in cases of intractable pulsatile tinnitus, or in cases of epistaxis in anterior cranial fossa dural AV fistula, or there is an intractable indirect CCF. The ideal size of the particles that we should use is 150 to 500 millimeters, because the smaller particles less than 150 millimeter, they will penetrate the EC-IC anastomosis and that can result in the ischemic stroke. Particle size larger than 500 mm will cause proximal vessel occlusion without any symptom improvement. Then a few words about gamma knife radiosurgery. Its indications are in the low risk region or the lesions that are not amenable to endovascular or surgical approaches. Here the lesions are irradiated with 20 to 30 gray energy, and this results in the venous thrombosis and fistula closure. The latency period, however, it ranges from several months to years, and this technique, this gamma knife radiosurgery is contraindicated until completion of vessel thrombosis. The hemorrhage risk is elevated, and hence stereotactic radiosurgery is inappropriate treatment in inappropriate primary treatment in dural AV fistula with cortical venous reflux. Some lines about the perioperative management. Overnight admission to ICU or HDU is required for the patients following embolization with dural AV fistulas. And if a large segment of the draining vein is occluded or it shows sluggish flow after embolization, we have to anticoagulate the patient with heparin for 24 hours to avoid the excess venous thrombosis. Because venous thrombosis, it usually leads to parenchymal edema and inflammatory changes, and it is better to place the patients on weaning course of dexamethasone. So the take-home points: dural AV fistula are most often acquired. They have different venous drainage patterns, and they have different arterial supplies. And we have to keep in while embolization, we have to take care of the EC-IC anastomosis and the vasa nervosum, and the anatomical reach and fistula is anatomical reach is used to guide the treatment strategy. The treatment is either by arterial or venous route or combination with the multidisciplinary team of neurosurgeons and radiation oncologists. The aim of the treatment is either the complete obliteration of the fistula or reduction of the cortical venous reflux in case of an aggressive fistula. These are my references. Thank you.
Thank you, Ekam,
Thank you.
for taking us through to a very complex topic and showing schematics and angiographic disposition to make it a simple thing. And you have completely covered the extensive topic. So do you have any questions? Okay. So we conclude?
Yes.
Thank you very much.
Thank you.
Bye.